All right, we'll get started. Thank you everybody for coming. This is our AWAEM Research in Progress talk that we do almost every single year. Confronting Disparities for Evidence 2025 AWAEM Research in Progress. So I'll go through a little bit of some background and then I'm going to turn it over to our amazing presenters who are going to talk about their really incredible research. So some disclosures, I am a member at large of the SAEM Board of Directors. Doctors Barringer, Jarman, Love, and Rahman were funded by the AWAEM Research Funding Award, and Dr. Moser was funded by the SAEM Foundation AWAEM grant, and they might have further disclosures we can hear about. So just a little bit of background on what this is. So this is the AWAEM Research Funding Award is money that's available to anyone who's an AWAEM member who is looking to start kind of in their research careers. It's intended to support projects that are aligned with the AWAEM mission, which is basically kind of supporting the promotion, the retention, women in academic emergency medicine. And the other component of it is to support AWAEM members, right? And so a lot of the work that we do, at least starting off, is sometimes unfunded, right? It's work that's important, it's work that kind of gets things off the ground, but we do it without any funding. And so this is a small way, a very small token to get some funding, and it's national funding, right? Even a small amount, which also goes kind of a long way when it comes to putting things in your CV, when it comes to putting this talk on your CV for promotions. And so little things like that. This award has kind of a lot of things that are packed into a very small project here. So just to give you a sense of it, as you're listening to these projects, I want you all to be thinking about yourself in this position, right? You're thinking about yourself, thinking about your residents, thinking about your junior faculty, and perhaps projects that might also fit within some of the things that we're talking about here. So this particular application is ideal for small projects, things that are generally not being funded by other things. They're very small. We've made the application very simple, very easy. There's no letters of support. There's no big budget you have to submit. It's really just about getting your idea out there and really getting the work started. And the other part of it is that we try to provide this forum for dissemination. So every year we do this talk, so you can actually get your research out there, get feedback from the people in this room, and think about what the next steps are going to be. So like I said, the goals of this talk, it's a national forum. I want you guys to be thinking about your work and how you might want to apply to this for this coming cycle, which will happen this coming fall. Just to give you a brief sense, we're all about data. We're collecting a little bit of data. This is now our 6th time that we've provided this money through AWAEM. We have supported 25 projects, over 85 investigators. And from the results of all that work, think about papers, national presentations, new research partnerships, further study, additional funding, policy change. And this is just a small snippet of papers that have come out of projects that are directly funded by this particular effort here, right? This is just a small snippet. So this is incredible. And these are all women who are in this room and who've been doing work with AWAEM for a while. So with that, I'm going to stop talking and I'm going to turn it over to our amazing presenters. Our first presenter was unable to join us. I will just kind of briefly talk about the background of her study. Hopefully we'll hear from her in the future. But our presenters today, Dr. Barringer, who's not with us, workplace interruptions and their impact on emergency department attendings and residents. Then Dr. Jarman will speak next, the influence of emergency physician gender on quantitative and qualitative patient experience surveys. Dr. Love will discuss her work is Med Tox for Women, examining gender equity in medical toxicology and national assessment. Dr. Moser will then speak about non-promotable task completion by academic emergency medicine junior faculty. We can all relate to that, I'm sure. And then Dr. Rahman will speak about empowering women in EM leadership, evaluating leadership self-efficacy after a case-based workshop. So huge spectrum of topics, all relevant to people in this room. So just briefly, Dr. Barringer's study, I want to make sure we give her some credit. She will hopefully speak with us later. Her work is about workplace interruptions and their impact on emergency department attendings and residents. Just a brief kind of view of her project. I won't be going all over herself, but basically she was looking at the frequency and types of interruptions in the emergency department, understanding whether there was perhaps a gender kind of component to those interruptions, and then a little further study looking at any additional patterns and trends to that. So that's just the setup. She will tell you more when you get to speak with her. So I'm going to skip forward to the next one. Here we go.
Perfect. I'll go ahead and start. Thank you so much for that introduction, and thanks everybody for being here. It's nice to see a full room. And I'm glad that you introduced the grants that way, because I think it's so important for people to know about these, especially maybe rising PGY3 residents that have scholarly projects going on. These seed grants are really awesome ideas for that. This is the second one I have had, and the first one was you had it on that slide, but it ended up in a J&O paper that Lauren Westifer and I did. So like you can do some real stuff, and we all do a lot of unfunded work in the beginning, but unless you're a statistical whiz, which not everyone is, there's some stuff that you just need money for. So that's what we've always used this for, is for things that we can't do ourselves, like advanced statistics. So keep that in mind for everyone. All right, let's see, I'm gonna use, oh yeah, this is my disclaimer, although very ironically, I am actually on a funding bubble right now because it's a long story. There's some stuff going on with the federal government. Usually I am funded by a Birch grant that I have to tell you as well. Okay, so patient experience surveys. How many of you love them? Yeah, I hate them. And I will tell you the motivation for this project. So patient experience surveys, we're using that instead of Press Ganey, but most of us use Press Ganey, right? It's supposed to, they use the term quality as if it assesses quality, but what it really assesses is the patient's experience. There is value in understanding the patient's experience, but that's a distinct thing from healthcare quality. And I like to make that distinction. I became interested in these because in some places, people actually use these scores to evaluate physicians. I feel like it's moving by itself. Am I imagining that? Okay. And they used to send out to us once a month or once a quarter the patient experience surveys, and I would read them. And every time I read them, I got very angry because there were a lot of them that said I never saw a doctor. And I was like, that just simply can't be true. So to be perfectly honest, that is why I embarked on this project like quite a few years ago, actually. They're used to evaluate physicians, and I thought if there's built-in bias here, that is not fair, right? If some people's bonus structure is based on what their scores are. We all know that you can get good scores by giving people antibiotics and ordering more CTs. However, that's not the right thing to do. So anyway, that's where this project came from. And of course, I have a background in sex and gender equity. So now let's talk a little bit about gender. You all probably know, since you're here, right, that gender is like time and context dependent, right? But those are sort of normative behaviors that we ascribe to feminine and masculine sort of gender presentations. Communal traits are basically descriptors that describe behavior that's focused on building community, which, as you can imagine, is typically ascribed to femininity in our culture. So communal traits like kind, compassionate, friendly. Please come on in. There's plenty of space up here. In our culture, in this day and age, are typically ascribed to women, right? And agentic traits, which are more like action and competency based, are more often used to describe men. A lot of that comes from the sociology literature, but it has eked its way into the medical literature as well. So we set out with two objectives. One was to look at the association between physician gender and quantitative scores, and the other was to look at qualitative descriptors used in the free text portions of patient experience surveys. And this is an important point too. I gotta editorialize for a minute, forgive me. This is why research is so important, and why like gender research is so important, because my hypotheses were all wrong, right? Some things are biased, not all things are biased, and we have to investigate to see if they work. So it is. It's really weird. That's fine. We hypothesized, first of all, I hypothesized that all those people that said I never saw a doctor would have seen a female resident and a female attending. And it actually turned out that that was not true. They actually did see a doctor. They saw an advanced practice provider. So I was wrong about that. And I was happy to be wrong about that, to be clear. But we also thought that women physicians would be described in these more communal terms, because that's sort of like typical. There's precedent for that actually in the literature, particularly in the sociologic literature. And I thought they'd get the same numbers essentially. So what we did was a simple retrospective cohort study. We looked at 3 years of data. That tells you when we started, apparently in 2022. And here we are. This paper's about to go in. With a lot of convincing, we got data from the patient experience office at our institution, de-identified data. And it was supposed to be on patients that are just discharged from the ED. Maybe it's just timing me. Our primary outcome was the use of these descriptors. So basically, we don't want to say qual because it's not exactly qual, because we did quantify it in the analysis, but we were looking at basically the adjectives that were used to describe the doctor specifically. So only from the doctor section. And we trained several reviewers. We had a med student, a resident, and then 2 attendings that served as sort of co-PIs. And we coded all of these, and it was blinded. I feel like No, here we go. Okay. And we were blinded to the genders of the physicians when we were actually doing the coding. And then we basically co-coded everything. We started with just having the meds do it and the resident do it, and then we ran a kappa with us, and it was not very good. So and then we just went through and sort of did it all ourselves, the PIs, to be sure we had consistency. So the secondary outcome was the quantitative portion, and this is just to show you what this looks like. These are the actual questions, so it's a Likert score. And I want you to pay special attention to the words that are used in asking these questions. Courtesy, time, listening, inclusion, right? So that comfort. There's a lot of actually communal words that are prompting you in the survey. And then this is where we took the free text comments from, if they were in this comment section, which applies specifically to the physicians. So we did some descriptive statistics. I initially did this analysis myself, and we just did a regression model. And then we used some money that we got from a grant to get a statistician involved to do like a mixed effects model to control for physician and for both attending physician and resident physician gender. So we ended up kind of pairing people up as like team woman, team man, or mixed team, and kind of evaluated them that way. And then our covariates you'll see here. So we had other demographics about the patient, we had other demographics about the physician, and then we had some operational variables like length of stay, and we actually had MEDOC score as well. And I should also say, I'm saying sex and gender on purpose because for the patients we had the legal sex. For the physicians, we actually were not able to like poll everybody about their gender. So this is sort of a assigned gender based on the pronouns that are used and the gender presentation of those physicians in our department. So you can see we started out with almost 5,000 surveys. We had to get rid of a lot of them because our data people are better than the patient experience office at knowing who was actually discharged. There were a lot of ones that we kind of shouldn't have received. And then we also got rid of people who only saw an advanced practice provider and who were primarily trauma activations. So level 1 and 2 trauma activations we got rid of because they're primarily trauma, right? And they see so many doctors, we have no idea who they were talking about. And so then that first block there is the cohort we used to look at the quantitative score, which is bigger. And then the ones that had free text comments we evaluated below. All right, so this is table 1. There's not a whole lot that you need to take home from here except to know that those two cohorts were quite similar. This is what our patient population this is not exactly what our patient population looks like, but like the racial breakdown, you'll see this is California, right? So we had, mostly white, and then number 2 in ours was Hispanic. They stayed for a long time, middle age, but it is notable that like the respondents are mostly white women, and that is not mostly who we care for, right? So there's obviously selection bias baked into who responds to these. And then these are the physician characteristics. So the physicians are mostly white men. Also not surprising, right? That are in our group, probably the same as your group. And then this table, I apologize, the formatting got a little bit messed up here, but this is basically the mixed effects model. And you don't have to look at it too closely because the kind of punchline is that it was effectively a negative study, right? So this is looking at our primary outcome, which is the use of positive communal and agentic descriptors, which if you'll remember, we thought would be related to physician gender. But if you just look at the p-values, none of them are significant, right? And these adjusted odds ratios are quite close to 1. So we actually did not find that gender was significantly associated with the words used to describe physicians. Interestingly, in the quantitative portion of our secondary outcome, we did find that women score higher. That first table we see there's a t-test, which is the wrong test because it was not normally distributed, but that's just the easiest to understand, and we ran it in every way we could, and in every model, women overall scored higher. But again, 4.48 versus 4.41, it's hard to say whether that's clinically significant or not. Probably not. And then down below, you just see a linear model that showed the same thing in a multivariable model, as well as showing that longer length of stays are related to lower scores, which is not surprising. And that older patients give higher scores, which is interesting. So putting it all together, of course, this is a single center study. Of course, this is an academic medical center. So those are certainly limitations. But I think one of our primary conclusions is thinking about priming and the questions that were asked in the survey. So in the literature at large, there's lots of mixed data about the role of gender in patient experience surveys. And there are certainly sub areas where women consistently score higher. And those tend to be the communal sections. So parts about shared decision making, listening, time spent. So our hypothesis of what we're writing in the discussion essentially is that we think we primed communal traits, or we think this survey did by asking questions the way that it did, and that may be why we had a negative result, because there are other studies that have used natural language processing that have found the opposite, or found a positive effect for gender, that women were more likely to be described in those communal terms. So that's kind of where we're at. I was happy to be proven wrong in this case, but like I said, that's why the whole process is important, to go in with an open mind and see what you find. And yeah, that's pretty much it. Let me know what you want me to say. Questions for the end?
Yeah, let's do that.
Yes. Okay, great. Thank you guys so much, and thank you everyone.
Yeah, okay, perfect. Great. So just in echoing what Dr. Jarman said, like, this is a really great award, and I think this is the third time I've gotten an SAEM award. So the first project, and just to give you like hope and like, thinking about applying for this, like the first project I did when I was a fellow, we did a modified Delphi study of women's professional development groups and developed like sort of a consensus around what women's professional development groups should sort of be responsible for, not responsible for. And it was a really great project, and we got that published. The next one is one that we're writing the paper right now, where we did qualitative interviews with faculty members about their job negotiation experiences coming out of research fellowship. So we're actively writing that paper right now. And then this is the third one that I'm still trying to launch, but I'm MedTox trained and research trained, and so I have started working within my subspecialty of medical toxicology, looking at advancing gender equity in that space. And so I did a paper, which I can talk a little bit about, where I looked at publication and sort of gender distribution in publication as first author and last author, where we took all publications over a decade in the two biggest MedTox journals and looked at using the Genderized IO tool, the gender distribution for first authors, last authors, and then predicting if there were certain variables, like based on the research article or the like the age of the junior faculty member, if there were predictors of whether or not there was a woman in the first author position or the last author position. And what we found overall is that luckily, as the in MedTox, as more women have entered that subspecialty, we're seeing an increase in the number of both female first authors and last authors, although the last author position is still largely underrepresented for women. So coming out of that work, I started working on this project, where we basically are looking at this now in more leadership positions over time, and looking at the last 10 years, the different leadership positions within MedTox, whether that's on editorial boards or on national organization boards, poison center directors. There's a lot of diversity of leadership positions within our subspecialty. And so we're going to be collecting administrative data from the two biggest academic toxicology organizations to look at the distribution over time. And then we're hoping to evaluate if gender, academic rank, years, like what predictors might determine if there are women in leadership roles or not, across all 5 categories. So the way MedTox is sort of set up, as I alluded to, is that there's 2 big professional societies. There's the American College of Medical Toxicology and then the American Academy of Clinical Toxicology. Each one has a medical journal. They each have an executive board. One focuses more in the education space, and one focuses a little bit more in the administrative space. And so we'll be looking at both journals, both executive boards, but then looking at fellowship directors, poison center directors, and then division directors. And I think so far what I've ascertained is that it's very hard to get administrative data, and then to get sort of the corresponding publicly available data about where these individuals are, how long they've been in these positions and whatnot. So luckily, up to this point, we've gotten the green light from one of the journals, one of the executive boards, the fellowship directors, and the poison center directors. So we will be able to look at positions there. We're working on one more executive board, and then one journal actually says they don't keep a list of their editorial board members, so we've sort of struck out in that space. But it's okay. Yeah.
They have.
Seems legit.
But so the aim one in terms of the analytic plan is that we're going to look at the male versus female frequency in each of these individual leadership categories by year, and then look at the percent change over time. And then the plan is for aim two to do both univariate analysis and then multivariable analysis to look at both the individual leadership positions. And then I expect that it might be underpowered in looking at those individual leadership positions. And so we may need to group everybody into just a group as a national leadership position and put all of these leadership positions together and try to do the regression in that way to hope that our power is enough to detect any sort of difference. So as I can demonstrate to you, there are a lot of challenges with this as you're trying to launch some of these smaller projects, but I think now with this being my third one, I've come to, understand that this is a marathon and it's not a sprint, and nobody in receiving this award is expected to be able to present results at the end of a year. And so, the AWAEM Research Committee is very much available to you as a resource for coming and presenting works in progress at their monthly meetings. We have a research consult service, so there's an email that if you do get this award and you're running into problems, whatever they are, IRB, data collection, analysis, we have an amazing team of people who want to help you, and so you can always contact the research consult service. But I have an amazing team supporting me of these 4 women here, who I'm very thankful for, and I'm happy to answer questions at the end.
I'm gonna hope this clicker works, and I'm gonna break the trend and stand over here and be very short. Okay. So hi, my name is Joanne Moser. I'm an assistant professor at the University of Wisconsin-Madison. I'm gonna echo Drs. Jarman and Love. I don't know that I'm allowed to be saying this, but while I had been thinking about my project for a little while, the actual grant writing process happened over the course of a week. I went to my fellowship director 2 weeks after starting fellowship, and I was like, this is something I'm really passionate about, and got the support to write this. So it's definitely something that is doable by all of you, because if I can do it, you can definitely do it. All right, I'm here to talk about my SAMF AWAEM funded study, which originally was titled Non-Promotable Task Completion in Emergency Medicine Chief Residents. That is no longer the title. It is now academic junior faculty, and we're going to talk about the impetus for this change in just a little bit at the end of the portion of this presentation. So this story all kind of starts about exactly 2 years ago in spring of 2023. I was a couple months away from finishing residency. I was a chief resident at a program of 100 residents. Yep, it's a lot of residents. And we had 6 chiefs, and only me and one other chief were female. And I couldn't help but notice that the type of tasks that the 2 of us were being asked to complete were very different than our male counterparts. And I happened to mention this in passing to one of my friends who wasn't in medicine, and she promptly sent me this article. So this is an April 2022 article from the Harvard Business Review talking about non-promotable tasks. So what are non-promotable tasks? I'll also be referring to them as NPTs for short. So these are tasks that are necessary for the function of an organization, but that they don't actually lead to career progression by the people who are completing these tasks. So think about things like taking notes in a meeting, planning the office holiday party, that sort of thing. And what the authors of this study found, they are Pittsburgh economists, and actually wrote an entire book about this. Is pretty staggering, but probably anecdotally not all that surprising. So they looked at various companies and businesses around the country, and they found that women are 48% more likely than their male counterparts to volunteer to complete non-promotable tasks within their organizations. But even if they're not volunteering, their supervisors are much more likely to assign them these tasks again. And this actually adds up to be something very significant. So in the businesses that they studied, the average woman completed 200 more hours of NPTs than her male counterparts in 1 year. That's pretty staggering, right? So why does this matter to us in medicine? And it matters partly for this reason, I think. We don't know for sure. So in 2020, there was an article published in the New England Journal of Medicine by Richter et al. And basically what they did is they matched med school graduation and faculty data going all the way back from 1979 to 2018. This included 559,098 medical school graduates from 134 US schools. And what they did was they basically calculated the expected rate at which women would be promoted to things like associate professor, professor, or department chair. And then they looked at the actual number and they saw a huge deficit. And the thing that kind of made me a little sad to realize was that when they looked at the later years, so any year past 1998, that deficit didn't actually decrease. So basically, we as a country are making no progress in terms of promoting more women into higher positions within academic medicine. In fact, in one of those areas, the gap actually widened. So there were less full professors from 1998 onward than prior to that in medicine. Whereas there's 38% of US medical school faculty are women, only 21% of full professors are women. So that's a pretty huge gap. So why is this? I don't think we have any conclusive data to say, what is going on, and I think it's probably multifactorial, but my hypothesis is that non-promotal tasks have something to do with this. If you are spending 200 more hours on average per year on something that's non-promotable, you're not doing the things that could get you promoted. But we can't even determine if there's a link between non-promotable tasks and this deficit in terms of promotion because NPTs haven't been looked at in medicine at all, in any specialty, including emergency medicine. So this is where this project comes into play. So I mentioned to you, we initially started this out in chief residence, mainly based on my own personal experience, but we decided, based on the Richter study and also on the fact that faculty, unlike chief residents, can actually get promoted, to switch our focus to junior EM faculty. And so this study has 3 different aims. So the first aim is we have to create a list of tasks, non-clinical tasks, so we're not talking about like signing charts, doing things on shift, but non-clinical tasks that junior faculty in EM are doing, because that list doesn't even exist anywhere. Once we're done with that, then we can assign promotability to those tasks. Which of these are non-promotable, which of them are promotable. And then finally, the third aim is going to be to actually take a look, have junior faculty, a sample of junior faculty log those tasks and to see, is there actually a gender difference in the amount of NPTs that are being performed. So we are done with the first aim. So we enrolled 5 junior faculty, academic faculty from across the country, and did something which is called nominal group technique, which is basically a fancy way of saying this structured brainstorming session where everyone comes up with ideas silently by themselves before the meeting. And then once we get to the meeting, they present their ideas in like a round robin format. We discuss, we vote, and we quickly come to consensus and created a list of 23 tasks, non-clinical tasks that junior faculty across the country complete, and we divided them into 5 different categories. So education, service, professional development, administration, and research. So that's done. So our next step, aim 2, what we're going to do is we're going to, via a modified Delphi process, get together a group of department chairs and other like high-ranking members in departments who are responsible for promotions, and have them take those 23 tasks and say, okay, this one's promotable, this one's not promotable, so that we have like a gradation. And then finally, we're going to get a national sample of junior faculty to prospectively log their tasks over the course of 3 months, and then analyze that data to see, is there actually a gender difference? And I just want to say a really huge thank you to 2 of my mentors, Dr. Jen Love and Dr. Ben Schnapp, for all of their help and their unwavering support in this project, and also to AWAEM and SAMF so much for funding this research. Thank you.
Right, so I'm Jareen. I'm at Sinai. I am not a researcher. I do more operation and informatics, i.e. what I've been told is where academic careers go to die. So I'm really excited that I got this funding so I can actually build on the work that I care about. And a big part of that is having more women leaders in operations. I was inspired to do it a couple of years ago. I looked around the room at one of the admin and ops committee meetings for SAEM. And the only other woman was a woman I brought with me. Who was my co-fellow, and wasn't very reassuring. So I really wanted to create a space where we really brought together women leaders and talked about our collective strengths and ways to really promote each other in this space. So background, I mean, we talked about this, and unfortunately there's a plethora of research on this, so I will not do a deep dive on that in terms of underrepresentation of women in EM leadership. And I also was a women's and gender studies major in undergrad, so I do think a lot about how women are perceived in society and how we are compelled to navigate society and the power dynamics that be. And there are some traditional leadership traits, and you already talked about that, Dr. Jarman, but agentic traits, right? Assertive, dominant, and then communal traits, empathetic, collaborative. Those traits are leadership traits, but they're not traditionally rewarded. And when women do enter more agentic traits, they are often penalized and are seen to be quote unquote less likable, or insert X, right? So we do get penalized. At the same time, the communal traits are core parts of being leaders that I don't think until recently, honestly, recognize that this is a strength, not a weakness. So really the purpose of the project that I was very grateful to get funding through AWAEM for was we did a joint didactic with the SAEM Admin and Ops Committee and had this amazing panel of vice chairs and chairs who were women at different stages in different geographic areas, thinking through how they were able to really elevate and amplify their communal leadership traits, really align that with their role. And also we're able to ultimately use a case-based workshop on a topic that many admin folks struggle with still, radiology throughput. So that was our case. And really we're able to all sit through together and kind of think through what that would look like. So the objectives really, we started off with a panel. We had 4 different panelists who really were very gracious in giving us candid insight into, we always look at their end posts and think, wow, they had no fails. They were very candid about all of the different failures along the way and what they learned in that process. And a lot of that was how they were picked up some survival strategies in navigating a very male dominant space. And then followed by the interactive case-based discussion was really getting their input and then working together to think through actually these things that I do, relationship building, making sure that everyone feels motivated and included, which, again, not trying to perpetuate stereotypes, but those are strengths that everyone has, and we in particular, again, because of how we've been compelled to navigate society, have developed. So we use a leadership self-efficacy scale. It's a 21-item validated scale. We did not want to use all 21 items. It was a pre and post didactic survey. So we adopted an item from each of the 6 dimensions. You will see to your left, leading change and choosing team in some ways are more agentic. And then to your right, motivating others and gaining consensus are more communal. So leading change, what does that mean? Basically, there were self-reported outcomes related to I am confident that I can lead change in a group, even if I can't control everything. Choosing your team. I am able to effectively choose members of my team to lead. Relationships, I am able to do good relationship building with all members of my team. Self-confidence, I have the confidence to get things done, which was to a sample ER doctor, so, take it for what it is. Motivating others, I as a leader feel confident that I can motivate others, but also give them opportunities for growth. And then gaining consensus. I am usually able to gain consensus among the groups that I lead. And so, we adapted that. We took those 6 dimensions. We used a 7-point Likert scale and wanted to see the impact of this type of snapshot of one-time intervention with the goal of expanding this into a more longitudinal program, which we're actually building now with ramps. This is just a distribution. It was a self-selected group, right? The people who showed up to this workshop are probably people who are thinking about leadership, so I recognize that. But at the same time, one thing that you will notice under partially disagree, the one field that's still negatively skewed is leading change. And the whole point was really to use the session to empower our participants to think of themselves as agentic leaders as well. I also did T-test. I know it's not the best test, but that's the test I use as well. And was pleasantly surprised to see that in terms of leading change and choosing teams, in terms of building effective teams, after the intervention, we were able to have an impact. And so in total, we had 51 submissions after this didactic. But as you know, right, like when you're scanning the QR code, and I'm guilty of this as well, you don't always do it pre and post. You're like running in and out the door. So 18 of them were actually true pre and post that we were able to use in this sample. So small sample size, acknowledging that. But what I took away from this was, in some ways there is potentially a ceiling effect in terms of communal traits. People are good at recognizing that, and we kind of expected that. But being in a space where you're now identifying that as leadership, things that again are quote unquote like community building, relationship building, like skills that we don't traditionally see rewarded in the leaders that we work with, our leadership, and that we are capable of having agentic traits and being leaders in that space. So, what implication will this have moving forward? One, it was really validating to see that having, and including for myself, I walked away feeling really inspired. You have these role models who again talk about how they, in very specific ways, have used these communal traits and have grown in being good leaders. Also validated for many that some leadership examples, just because they're in those spaces, aren't good leaders. And in male-dominated environments, those are the types of behaviors that sometimes get rewarded, but that does not make you a good leader. And so how do you counter that? I mean, yes, education is part of that, and mentorship is part of that. And again, if you're interested, selfish plug, I'm now more involved with Admin and Ops Committee. I'm specifically thinking about building more mentorship for residents and junior trainees. But you need to also have other types of reform, like we talked about, in terms of being very transparent, in terms of how are you promoting people, being very transparent, and how are you giving people certain roles and titles, recognizing that the onus can't be on us, right? We need allyship, but you also need institutional accountability, which I'm very grateful that other people here in this room that have spoken before me are really supporting. So the conclusion for me and from this project was, we know leadership is multifaceted. We know communal traits are really important. We also know that if you are able to be in a space where you're actively applying those skills in a case, and you're actively seeking the insights of chairs and vice chairs who give you feedback and let you know that this is what I use to actually climb the ladder in a way where I was still navigating the unfortunate gender stereotypes that we do have to navigate, right? Again, agentic traits, there is well-documented research that women who engage in that are penalized for that. I know I'm preaching to the choir, but we know that. So allowing yourself to embrace the communal traits, but also giving yourself the confidence to really espouse the agentic traits, we found was very impactful. So next steps, I already talked about mentorship. This was an AWAEM and SAEM admin and ops didactic. We're actually working right now with A1 to do more of this in terms of building that pipeline out in a more longitudinal manner, not just a one-time didactic. Bias training, it's interesting. I wrote this before some changes happened in our government, because I remember just 2 days ago, we were talking about faculty evaluations, and one of the participants was a faculty member in Texas, and they found, I think they haven't studied it rigorously, but they found a pattern of women faculty being described as more aggressive than male faculty by residents. And she even commented how the representation of leaders was actually relatively better than from other places, and the resident gender breakdown was actually also fairly even. But we also know what internalized misogyny can result in. But when we all brought up bias training, she said, I can't do that. Can't do that in Texas. And so I wrote this before that I recognize for my colleagues who are in states where that is not a possibility, that, you know, that is not a solution that we can offer, but we do have spaces like this where we can bring our colleagues in and hopefully expand that space, not just to folks who already live this every day, but to folks who do not really live this every day. You know, just yesterday we've had discussions about how do we even empower our non-physician colleagues, like our nurses, our techs, also to be encompassed in this type of training and recognizing that there are gender stereotypes and how physicians are perceived. And then I'm really glad you're doing the work around how we be transparent with equitable promotion policies. But that's all I have. Thank you.
Okay, we do have some time, so please don't leave. So what I'm going to do is I'm going to scroll back to the top here. I have lots of things I would love to pick your brains about, but I want to make sure that our audience gets a chance to ask any questions. And feel free to use this space also to ask questions about their particular projects. I put the titles back up here to jog your memory. But also if you want to ask about the research process, right? I'm going to, if no one else has a question, I'm going to ask you all to talk about what's hard about this, like getting things off the ground, challenges, roadblocks. So think about maybe some of those things. But does anyone have a question for any of our guests? Let's start here.
I'm Monique Arnold. I'm a Vietnam Summit. Thanks for your talks. Not to Jarman specifically. I had a question about kind of the distribution that you found of your patients and of your faculty. You said that you found no significant difference in kind of any of the domains that you explored, but your sample is driven mostly by, as you said, 40-something% white women.
Yep.
Did you look at breakdowns within the subgroups, men versus women, white women, women of color, etc.?
So we explored that a little bit in terms of looking at gender dyads, like if there was the same gender between the physician and the patient, and we did not actually find anything. There is, however, you're probably aware, there is good evidence about that, right? That like there's a survival benefit for a woman with a heart attack when her doctor is a woman. That's important. There's some race-based literature as well. I think our sample was probably just too small to find that, but I made that comment because I just want to emphasize that like patient experience surveys do not describe all patients' experience. They describe richish white women's experience, right? Like, I don't know if they're rich, but you know what I'm saying? Like the demographic that's returning these. Well, like we work in Sacramento, we take care of a very diverse patient population. Our population is not 46% white women that we see in the ED. That too happens to returning surveys. So it's really biased just to emphasize the results of a patient experience survey, which doesn't describe the experience of the majority of the patients that you take care of. So I think that's the reason I made that comment, to just say, I think we have to recognize and take that with a grain of salt. If you go to work somewhere where they say, oh, you're getting punished because your scores are bad, you're like, okay, well, my scores from one specific demographic were bad, and also what are we measuring? That's a long answer, but great question.
Yes, in the back.
Hi, Anna Heffern. I'm a PG here at Sinai. I have a question for Dr. Moser. So for the MPTs that you're finding, is your goal, or ideally would you want to see those made more promotable, or would you want to see them more equitable? I'm curious about your thoughts on that.
Yeah, for sure. I think that's a great question, and one that's like actually addressed by the economists in the book that I was referencing. In that, like, something that was like a little disheartening for me to find was that, like, when women become aware of this problem and they say, well, I'm just gonna like more consciously say no to a certain non-promotable task myself, it turns out that like it usually just gets assigned to another woman. And so I think this is very surprise. And so I think this is something that, like, why I feel so passionately about like finding the data for this is because I think it needs to be a top-down solution rather than a bottom-up solution. Like, it's not enough for the people who are experiencing this to say something. I think like data is power in a lot of these spaces, and so ideally what I think should happen is that, like, I mean, again, we could have a negative study like Dr. Jarman, and I could be wrong, but I think we're going to find a difference. And then what I want to see happen is we take that information to chairs of departments and say, hey, look, this is a problem. This is like negatively affecting one specific, set of your faculty. And it would be ideal if a department chair would say, I'm going to write up every single non-promotable task that needs to get done in my department, and I'm going to evenly divide them amongst all of the faculty members. Like, I think that's the solution, because I agree with you. Like, I think we can make some things more promotable by like how like the incentive structure, but there's always going to be non-promoted paths. I think it's just about someone with the power to do so, even residing there amongst people who are looking. Thank you.
Yes, Beck.
If I could ask Dr. Moser a follow-up question. I do this year, I've been working on Sinai. How are you defining promotion? Are you specifically talking about academic rank, or are you talking about other forms of promotion? And I will sort of, part of my reason for asking that is as somebody who is on an administrative sort of leadership world and is involved in promoting people for sort of academic leadership positions outside of the track, things that might be considered non-promotable for academic roles are sometimes very promotable for, you know, a medical director role or things like that.
Yeah, definitely. That's like a very good question. And yeah, the nuance is not lost to me. I think like because this is something, and I think we were kind of talking about sort of like the struggles that we had during the research process. One of my struggles is that like none of this has existed in the medical space so far. And so I think what we're starting with is like very much that like very defined definition of promotion by academic rank. But this is like one of like literally hundreds of possible projects looking at all of these other like different types of promotion. But I think to start out with, we wanted something that was like very like specifically clear cut. So when we go to like the heads of departments and people who sit on promotions committees, that like they have a very defined spectrum. But yeah, there's definitely variability in what's promotable depending on what you use as a definition of promotion. Also like what type of like faculty member you are. Are you in the education space? Are you in the admin ops space? And so all of that nuance is going to be there. And like that's one of the struggles I think we still face is like how do we parse through that? So we're trying to make it as like rigidly defined as possible to start with, but
Which I think makes sense also because like then you can generalize across departments and like it's the thing that chairs are held accountable for to deans and stuff. So like picking something that is so structured like certainly fits. I'll make a comment on that thread as well that like is meant to empower everyone in this room. So for like the junior people in this room, being aware of this phenomenon is important so that when you're sitting in a room with a bunch of people and they're like, okay, we should take notes. Like don't just be like, okay, great, I'll do it, right? Like you know what I mean? I mean, sure, you can if you want to. You have to be aware because people might expect you to do that. And if you volunteer, like, you know, you're giving up your time and space. And then for the mentors, right, you have to tell your mentees this. I tell people this all the time, like, don't do non-promotable work. If you're a faculty member, your job is to get promoted, right? Like, you should only do work that you are passionate about and will get you promoted. And that's an important and. And I do have a question for you too, but also I want to add that Linda Babcock is amazing and also wrote a book called Women Don't Ask. That book was handed to me. It's a great book. Was handed to me by Cherry Hobgood when I was interviewing for a job, faculty job at IU, which I thought was very ironic. And I was like, I'm about to negotiate with you. I knew she was an important like sponsor for women, right? You all know her.
If you don't know,
Yeah, you should. You should know her.
I should read her work. She's amazing.
My one question was on your AIM-3 when people are going to log their time. I wonder if they're going to know. I wonder if they're going to know the purpose of the study because I think you are going to get some Hawthorne effect if you tell people why and that people might suddenly have some tasks they come up with.
right, we're not telling them. So anyone who's in this room is not eligible for phase 3. Yeah, that's been like the hard part of this study is like whenever I talk about it, making the title be as like nondescript as possible because I think the second people know that we're looking at like things that are potentially stratified by gender, it changes their responses. And so yeah, they're all blind to it. Yeah. Ideally.
Yeah. So my name is Brenna Farmer. I'm a New York Presbyterian in Cornell. I could say something to all of you. Dr. Jarman, I just have a question about how your patients get surveys.
Yeah.
Because that also sub-selects your patients.
Right.
And we use electronic surveys.
Yeah.
So if your patient gets an electronic survey, you've already cut down
Totally.
so that's another limitation to think about.
Yeah. Ours were by mail, but that's a different limitation, right?
Exactly. They have to have an address.
Yeah. Right.
And Dr. Moser, when you're doing your next steps of your study, I would say you need to look at which tracks each of these schools have because there are more and more schools looking at administrative tracks or operations tracks and having service on a committee or a leadership role on a committee is counting towards some part of it may not be a lot, but it may count towards something. Jen, we could talk all day about your study because I know that one inherently. And then Dr. Raymond, for your study, the thing I would recommend now is looking even outside of AWAEM at other emergency medicine women leaders who, like me, don't have enough time to go to all the committee meetings to participate, but I would really love to mentor as many people as possible.
Thank you, Dr. Barr. So I put up names and addresses here. We all are looking to collaborate. So if you have any further questions for our researchers, please feel free to reach out. If you want to know more about this next funding cycle, please let me know. We're excited to hear more about your ideas and get more projects going so we can really continue this really important conversation. Any last thoughts?
And the SAEM AOM grant budget has doubled.
Yes.
Recently, so there was more money to do more things.
That application is a little bit earlier. That's it's in the summer to get things together. And then for the AWEM internal funding award, that's a little bit later. But it's all available. So I want to thank you all. Thank you again to all of our presenters, and thank you.